Okay. Okay, for the panel today, it's about are we currently losing, holding, or winning the fight against antimicrobial resistance or PCR? Okay. Quite like the question that quite hit to the point. May I ask from the global view, from the native first, do you think right now you think the current surveillance system, do you think how reliable of the current surveillance system right now from the global picture?
Thank you. So the question was about how reliable the global surveillance picture is. I think as far as it goes, it's great. I think that we're really reliant on it for early warnings about the emergence of resistant organisms. I think as we heard earlier on, it's also lacking, it tends to focus on men with very little data from women and also very little data from extragenital sites. So I think the fact that we have surveillance is fantastic, but I think that we could invest more in surveillance and have better data on which to base public health policy.
Dr. Sapon, as you are role for the leader for the solar system in Thailand, what do you think about this point?
Yes, I think that I totally agree with Dr. Matthew that it is important to strengthen to the surveillance system in Thailand. Even we try to conduct the surveillance on STI clinic in each site, but when compared with the number of the infected patients, we think that the surveillance isolates that we receive still in the low number because of we faced with the difficulty to getting the specimen and the culture process is not easy. Even we have done in Thailand, but it's quite challenging for the clinics that is quite busy for they to getting the specimen.
So, move to Dr. Opat. As you are a clinician and a leader for the emerging division for the infectious diseases, what is the safe triazole fail widely today? What is your plan?
I think the best is to prevent, but if it's fail, we need to, as I mentioned, that we need to find the new tools for the treatment for sure, right? And then we need to have the system that track the people who fail. We need to diagnose. We need to have like many people mentioned before that we need to have the diagnosis, the accurate diagnosis that can identify people who fail and what they fail with resistance or they fail with the other factors, and then we can target them and give the second line or third line treatment to these individuals. I think that if we fail ceftriaxone, we do have options, but we're going to lose the option soon if we don't have antimicrobial stewardship for the control of use this agent, because we have the history that we have lost our weapons for quote-unquote treatments. Like in the past, we used to use penicillin. We have many agents like tetracycline, and we have lost them all. So we need to protect our new agents. So I think antibiotic stewardship is a key after we lose, and we need to have the diagnosis, rapid diagnosis.
I heard about in America that for the guideline they use the point of care technology for the virtual discharge syndrome. And how about in Thailand, Dr. Rapon, do you think how close are we having the point of care diagnostic that can guide
In terms of point of care test, actually we have some tests like Gene Expert. That is a kind of point of care testing also, which can receive the result in 3 hours. But for 3 hours is still long waiting for our patients. So thinking that you have to waiting another 3 hours in the clinics to waiting for the result. Yeah, I'm not sure you wait or will you go back home, yeah, and come back later. So I think this is quite challenging in terms of point of care testing that the speaker, Ajahn Pongpat, that already mentioned about this. How can we have a quick point of care test and also high sensitivity and specificity, including affordable price. The lastly is really important in our country. As I had some discussion before, that how much is affordable price for Thailand? Do you think how much that we can afford it? So I would like to compare with the syphilis and HIV testing, that this is around like 120 baht, which is $4 US dollars, some kind like that. So this is we can compare this price as an affordable price for Thailand. Yeah. But nowadays, gene expert only the costing that we buy from the company is reaching like 40 US dollar, yeah, for the cartridges and also the swab set. So this is like 10 times above that we can compare with the affordable price. So I don't know that how far that we can have the real point of care test that can be used widely, like rapid test for syphilis. I think that maybe could Ajahn Pongpat, yes, can answer this. I'm not sure how far.
Still very far.
Still, yeah.
Matthew, you have anything to add?
Yes, whilst the contexts are very different, these same financial restraints are present in the US as well. I work in the Johns Hopkins Hospital, which is a fantastic institution that has amazing resources. We don't have point-of-care tests for chlamydia and gonorrhea or trichomoniasis. I work at the Baltimore Health Department, the public health clinic, which is much less well-resourced. And we previously had the BINCS IO chlamydia gonorrhea test, which resulted in 32 minutes. And that was great. Patients were willing to wait. The clinicians loved it. The problem was that we lost our grant funding, and therefore we lost access to those tests. So even in situations where there's plenty of resources and where insurance companies should pay for these tests, they're often not sustainable at their current cost.
How do you implement some kind of regulation system?
I think that POC or point of care is very crucial, as mentioned many times before, that it helps a lot in terms of diagnosis. But when we don't have the affordable test right now, we need to prioritize who's going to benefit most from using point of care. That's my strategy, because we cannot give all the tests to all people. We need to think about what is the population that benefit most. I'm thinking about the people with high risk, very high risk for getting AMR. For example, men who have sex with men, sex worker, or people who fail the treatment. So we need to prioritize this group of population to offer them point of care tests. But if the test is not widely available, then give to all people.
So yes, we know about the plan B for the treatment. We know about the point of care test, how far we can have that one. And right now, do you think if we thinking about the AMR and STI, do you think what are the biggest system failure that driving AMR and STI from the point of view?
I think that there is not only one cause that can affect to the increasing trend of AMR. But I think that this is one antimicrobial factors. Yeah. So this is like since initiate of the beginning that patient go to reach to care that I mentioned earlier that they may have a symptomatic treatment. As I am a principal investigator for IGAS, I was found that 50% of people who have urethral discharge or urethritis, they may not be diagnosed as gonorrhea. 50 of them are non-gonococcal urethritis but has symptoms like urethral discharge or urethritis. So this means if we do syndromic in the hospital, this means that we prescribe 50% of antibiotic overuse that cover who do not have gonorrhea, which imply the same thing that implied in the pharmacies that Dr. Sutaya said. So 50 of them also may not gonorrhea. So all of that with expensive over antibiotic without, because we don't have the point of care that can be available everywhere. So those can be driven or drive the drug resistance in Thailand. Yeah, and also I think that because of the lack of good point of care test, this is the second factor that we cannot screen for asymptomatic patients, because I mentioned about symptomatic that who want to see the care. But for asymptomatic patient with a high-risk population that Dr. O has already mentioned, we cannot provide those testing beyond 15,000 cases right now, because this implemented by Global Fund. So many number of high-risk population in Chiang Mai, in Phuket, that we found antimicrobial resistance may need to be screened and have a rapid treatment also. So this is a second factor that can be contribute to this rising antimicrobial resistance.
In my opinion, I think that asymptomatic infection is, in my concern, is the main contributor for AMR, because people have symptomatic infection, they might receive antibiotic for the other disease like upper respiratory tract infection from over-the-counter drugstore, and the bacteria being exposed to some kind of antibiotics and then transfer the antibiotic gene from the other bacteria to gonorrhea. I think asymptomatic infection is play a major role in AMR, and also in Thailand we have a specific setting that you can find antibiotic from that store, right? So I think antibiotic stewardship in that store should be placed to combat with AMR, not only for STI but for the other pathogen as well.
I think I'm repeating what my colleague said, but the call for an integrated strategy that goes from education in schools through to education of healthcare workers, community pharmacy workers, and the general adult population, including people who are visitors to Thailand, it is an important part. But education enough is not sufficient, I don't think. You can have plenty of education, but you can still have a behavioural deficit. So trying to understand some of the modifiable behaviours that put people at risk for acquiring AMR is also an important part of the overall solution, along with vaccine development, new medication, public health strategies, etc.
I will bring you back a little bit to public health. Do you think are we too dependent on antibiotics instead of preventive strategy right now? for the STI. Based on we are like too dependent on the antibiotics. Instead of the prevention strategy. From your opinion.
Maybe yes, because it's a cascade. If you cannot treat, and you're going to have a vicious cycle of transmission chain. So I think that we need to move forward to prevention, and then we need to do. Now we are relying on the treatment because we see the tip of the iceberg, symptomatic patients, right? But I think we should move on to prevention that can cut or prevent chain of transmission. There are so many options for prevention, like we discussed in the morning. We start from education. We have many tools for prevention, for example, a condom and PrEP and post-exposure prophylaxis, and looking forward to seeing the vaccine for STI in the future. So it should be combined together. And the other thing is we need to change the mindset for STI prevention. When you see your kids have condom, don't blame them. They know the way to protect themselves from STI. We need to think out of the box. In this generation, you can. I think you should allow them to know about any kind of prevention. That's all for me.
Okay, I think we should also celebrate our successes. If we look at the success of HPV vaccine, for example, it demonstrates to us that it is possible to develop a highly efficacious, affordable vaccine that can be rolled out and really reduce disease burden. I think there's not that much money in bacterial STI vaccine development in terms of companies who develop vaccines, and sadly the latest data from CROI looking at the HPV vaccine was pretty disappointing. But we should learn what we learned about HIV and take all of these other things into account and really try and push the vaccine agenda. I think that's one of the things that will be transformational.
Now, I would like to add on from Dr. Opas and Dr. Matthew. So I would like to mention about integrating STI testing to other departments other than STI clinic, which is like PrEP clinic, HIV clinics, reproductive health clinics, sexual health in age clinic, which you already know that from the information from Global Funds show the high detection rate of gonorrhea and even chlamydia in the youngest population, like less than 15 years old, which we don't think that they will get the infections. But to promote those clinics, to let young people reaching to the clinics is not easy at all. Yeah, but once they walk into clinics, it means that they had problems and want need some help. So I would like to emphasize on this who work in the clinics that when you see the young people go to the clinics, it means that you should welcome them and help them, because if they do not have problems, I don't think that they will walk to the clinic. Yeah. So once they come, so please help them. So this I would like to emphasize.
I'd like to echo more about this because for people who seek for the treatment, one of the barriers is stigma. So we need to create a stigma-free environment in every clinic, and it's going to help a lot to allow people to come to the clinic and we can give the treatment earlier and prevent them from transmission. So I think our system we need to adjust a little bit in terms of strict stigma-free environment.
From my point of view, it's still like a very challenging for the STI and the stigma from that Dr. Opat mentioned. And also part with the situation of the AI and the fake news, some kind of that the information like overwhelming right now today, because of the new generation, they love searching for the internet, and some of the information on the internet is not that real, and also they more likely keep themselves secret, like more confidential and anonymous. Because sometimes they doesn't want to go to the clinic, and because sometimes they trying to seeking themselves for medication for some kind of that make the situation bad. Also, yeah. So any participant would like to discuss?
I'm thinking in terms of the transfer the result of your research work into the application to the healthcare system. What I can say there. So I think the symposium expert should provide a recommendation to the Ministry of Public Health that I think the criteria or guideline for transfer this kind of technology for prevent and combat persistent disease should be recommended by this group. I think we badly need this. And this is a very strong recommendation because it's research based, it's evidence based. So, in my opinion, the criteria for selection of the new technology to be transferred into the system should be 8 criteria, in my opinion. First, maturity of the research, of the tool. Is that mature enough to be transferred? You have to consider. Second, of course, efficacy. And the third, safety. And fourth, precision. And the sixth, rapid of the time. And other appropriateness for the self-testing or self-treatment is appropriate for the vaccine system, right? And then another one is, of course, effectiveness. And the last one, of course, supply chain to be used for the vaccine system. So I would like all of you to have the whole recommendation to visit Dr. Thank you.
Thank you so much. We are now the time for everyone.
Thank you very much for our distinguished speaker. And now before we conclude, I would like to invite Professor Antimicrobial to have a closing remark. So,
distinguished guests, colleagues, and friends, as we conclude this symposium, I would like to express my sincere thanks to our keynote expert from Johns Hopkins University for their inspiring insights and innovation in the epidemiology of the sexually transmitted infections. As alumni of Johns Hopkins over 60 years ago. I am deeply grateful for the foundation it gave me, one that I have carried forward in teaching and supporting my students here in Thailand. It is truly meaningful to see that legacy continues through your presence today. Thank you. Gratitude to Department of Epidemiology, to the Faculty of Public Health, Mahidol University, and to also distinguished speakers from Thailand for sharing their invaluable insights that we will carry them, this knowledge forward and turn them into decisive actions for a safer and healthier future. I would like to say that this gathering has strengthened our shared commitment to advancing public health with knowledge, collaboration, and compassion. I think I should officially declare the symposium closed. Thank you all, and have a safe travel also.